Yeah, sure.
Hi, good morning, everybody. So, today the topic of discussion is end of life care. I'm sure the minute we think of end of life care, the first thought that comes to our mind is, there is somebody who's terminally ill and there is somebody holding their hand and walking them through this. Well, end of life care is that and much more and beyond. So, today we'll just have a sneak peek into all the things that are included in this big spectrum of end of life care. So, end of life care is an approach that improves the quality of life for the patients and for the families with terminally ill, who have terminal illness, and it helps in identifying and gives a more comprehensive care to the patient, which is not only physical ailment, but there's also a social component. There's a psychological component, and there is a spiritual component that end of life care addresses. So, Aruna Shanbag, most of us in India would be aware of this famous landmark case in medical history. And for the ones who are not from India and have not heard about this case, Aruna Shanbag was a nurse who was sexually assaulted by a ward boy, and she remained in a vegetative state following this for about 42 years. A plea for euthanasia was filed by journalist Pinky Virani, setting up a medical panel to examine her. The court rejected the petition on March 7th, but however, a landmark judgment was passed. That is, India allowed passive euthanasia. Because of this woman who has never received justice herself, no other person is ever going to have a bad fate as she has had. So, coming to end of life care, who are the candidates who will benefit from end of life care? Anybody who has an advanced age with multiple comorbidities, individuals with poor functional state, chronic neurological disorders, advanced metastatic disease, patients who have had a cardiac arrest, CPR, and have a poor neurological response post the CPR are candidates who may benefit end of life care. But also, there are certain categories of patients with advanced diseases such as CKD, whose quality of life itself is poor, Alzheimer's disease, patients with cystic fibrosis. They are also candidates who can benefit with end of life care. So, ideally, when the diagnosis of a terminal illness is made, the palliative care should begin at that point. Initially, whenever a diagnosis is made, the orientation of the physician and the family is, can we get a cure to this? And over the course of the disease, as you realize that the curative response is less, or the probability of the patient moving towards a curative pathway is less, the palliative pathway should start increasing in support, and there should be more emphasis on palliative care. And when the patient comes more towards the terminal illness, we should think of end of life care for the patient. Who provides end of life care? End of life care is a team effort. It involves the physicians, the nurse, the social worker, family members, spiritual advisors where needed, and it has to be a multidisciplinary approach. Where and how can palliative care can be given? Palliative care need not always be in the hospital setting. It could be in the patient's home, in a hospital setup, or in a hospice environment, or assisted living, or a nursing home. This would be driven by the patient's choice, the family's preferences, and how the social factors play up for this patients. The important thing about palliative care and end of life care is it should be patient centric. Whatever is planned for the patient should be with the mind and the thought that what the patient wants for himself and wishes for himself, what type of death he wants, what type of life he wants for himself. A comprehensive assessment of the patient should be done, and a discussion with the family or the primary caregiver should be had regarding the goals of the therapy. And this should be well documented so that there is no confusion as the patient moves through this journey. One of the other non-medical aspect of of palliative care is financial and legal guidance. It is useful to guide the patients and tell them the details or help them navigate and coordinate through these complex and confusing healthcare systems and the requirements for their further care. Generally, patients who are terminally ill have a very prolonged course, and the duration is unknown. This creates a lot of anxiety in them. Having reassurance, clarity, and guidance, through the journey is very helpful for them. When anybody is told that they have a terminal illness, their first worry is, will I die with pain? Will I suffer, for every day that I live? The primary goal of palliative end of life care is that they should not have physical suffering. They should have a life which has quality rather than quantity. Symptoms such as pain, shortness of breath, fatigue, dyspnea, respiratory secretions, anxiety, these are the common symptoms that are faced by terminally ill patients. The requirements of the patient, the symptoms should be given priority, and they should not be denied treatment for these things because they determine the quality of life that the patient would have. There are lots of other components to a patient's health. It is not only the physical ailments, but it is their mental health. It is their social environment that they're living in. And it is about their emotional status as well. Because a terminal illness is prolonged and it takes a toll on not only the person who is suffering, but also the people who are supporting and walking along with the patient through this journey. So it is useful to have family meetings. A family meeting can be a very powerful tool to have a more comprehensive approach towards the patient and to plan a care. Having warm handoffs and referrals to local or community service providers to take care of the patient, to give them social security. Some patients are more spiritually inclined. When a person is spiritually inclined, it is not necessarily always religious. It could be non-religious as well. The caring team or the healthcare providers should be mindful of this and cater to this need as well, because this may be very important to the patient, and not taking care of this may distress them and hamper their journey. Sometimes they may require a priest, or when they are hospitalized, they may want a priest or a pastor or a chaplain to come and run through prayers. We should facilitate and accommodate these things. It is also good to be culturally understand the cultural backgrounds of patients and to be sensitive to their needs. This helps. We should respect their values, beliefs, and where possible, we should help them out with these things. If there are language barriers, linguistic barriers, we can have translators to help through these things as well. The journey through chronic illnesses and terminal conditions can be emotionally, physically, and mentally stressful for the patient and family. Helping them understand the journey and providing them with emotional and psychological support will be helpful. Caregivers are usually prone to some amount of social isolation because their entire life rotates around just taking care of the patients. And I think this we have experienced multiple times, especially in terminally ill patients or metastatic cancer patients. The family is constantly taking care of the patient. It generates a lot of fatigue in them. It generates anxiety. And they have a lot of health issues that they develop by themselves, a lot of psychological issues that they may develop taking care of somebody who is very ill. Having a 24-hour helpline or a pathway through which they can get information and help will be useful for these people. Where required, we can refer them to psychologists and psychiatrists for therapy as well. Whenever a decision is made for a patient, it should always be a shared decision making. This helps in the patient feeling supported, and they feel more reassured that their plan or their care is in the right direction. And the family also is satisfied knowing what is happening. They're more prepared for what lies ahead. It helps patients and families communicate with each other better. There is no absolute right or wrong way of doing. Whatever works for the family as a unit is the way in which we should make the plan for the patient. End of life care, the most important part is that period of imminent death. whatever happens in this period is what remains with the family. If it is a good and smooth process, the family will have closure. If it becomes turbulent, or if there are lots of ups and downs, or if they see their loved ones suffering, they may be traumatized for their entire life. And it is also not fair to the patient. They should have a right to die in dignity. So most relatives carry the burden and they feel guilty for what they're doing. So this period needs to be very smooth. Make sure that the symptoms during this period are well controlled. The death is not prolonged by adding unnecessary interventions. Where required, get the spiritual and cultural needs of the patients taken care of. And when you have time, you have assessed that this patient is going to deteriorate, it will be worthwhile to have these discussions with the family prior and prepare them that this is the path, this is the course of events that will happen. These are the things that you will see. See, you have a patient who's a metastatic lung cancer and you have decided not to tube this patient. There will be certain amount of suffering that comes, though you try to take away the pain by maybe starting a morphine infusion or giving sedation, but they may still see the patient becoming drowsy, becoming unresponsive, maybe gasping for breath. This may be very distressing for the patient and distressing for the family rather. Educating them of the process and knowing how things will go will help them cope with the situation. And post the death, it would be a good idea for the family to receive some counseling on the same. I think the ethical and legal aspects of care is one of the most challenging factors that has sort of put end of life care in India, at least at the back end, because most of them don't know what exactly the laws are. There's a lot of anxiety among the physicians whether it is okay or it's not okay. Do I have implications of doing certain actions? Will I be held responsible? Will I be sued? There are a lot of questions that come to a physician's mind, and we'll have a little discussions about the laws that are available in our country to facilitate this. Whenever we take a decision of end of life care, the first and the most important is autonomy. We need to understand what the patient wants for himself, what are his needs for his life and death. And if he's not in a position to decide, then his surrogate decision maker should decide for him. But the decision that the surrogate decision maker makes should be what the patient would want rather than what they want for themselves. This is a very fine line and tends to have a lot of confusion in clinical practice. And we have few case scenarios through which we will run, and we'll see how all of these become very gray zones and get blurred, and some of them get compromised as well. But when we move towards end of life care, we always should keep in mind what the patient wanted for himself, and whatever we do for the patient should have some benefit to the patient. And the important thing is to do no harm. If a patient is terminally ill, there is no chance of his survival. Subjecting him to unnecessary medical interventions, surgeries, or prolonging his life even on a ventilator, it is a form of doing harm to the patient. It is a form of injustice to the patient. So we should be mindful even when we are doing these interventions, whether we are doing any harm to the patient or are we doing any justice to what the patient wants. It is always important to maintain professional boundaries here, remain knowledgeable of what is the organizational policies. Different countries, different setups may have their own internal policies. It is handy to know what your hospital follows, what are the protocols of your unit, and communicate these decisions to the family and to the patients where feasible. So there are certain articles here. The end of life in the intensive care, better late than never. This is from the Indian Journal of Critical Care. From the Aruna Shanbag case, following this petition, the Supreme Court said passive euthanasia was permissible. But before we attempt passive euthanasia, a prior approval from the court is required. And Supreme Court also allows advance directives and living wills. But the process that the Supreme Court has put for advanced directives to be recognized is quite laborious, which makes it a complicated process for us to follow on a daily basis. Withholding life support and withdrawing life support in a terminally ill patients where death will occur are are strategies that can be followed, and they are allowed by law in our country. When the sorry. Then we have another one, 196th Law Commission report just by Justice Jagannath Rao. He highlights this law basically is for terminally ill patients, including patients who are in vegetative states, who wanted to die a natural death and didn't want any modern life supports or like artificial ventilation or artificial supply of food. This law makes it clear that euthanasia-assisted suicide is not permissible. It is unlawful to do these things, but withholding of life support measures to terminally ill patients, such as withdrawal, can be done in these patients if the patient desires. Okay, another article is March 28th, another verdict is on the March 2018 Supreme Court, which again says that passive euthanasia is allowed by law in India, but not active euthanasia. The 241st Law Commission report again states passive euthanasia, which is allowed in many countries, will also be allowed in our countries, but it has to go through a certain checklist, and it has to make sure that it is not harming the patient. The ICMR also recognizes DNR as a valid medical decision where, in the best judgment of the treating physician, CPR would be inappropriate or non-beneficial and likely to prolong the suffering of the patient. Our Indian Society of Critical Care has always advocated ethical and transparent decision-making, end-of-life care and palliative care in India. Yeah. Dr.
Yeah, I've got a little question here. Let's say, because I don't understand Indian law. Let's say you have a patient that was intubated in your emergency room, brought to your ICU. Now they're in your ICU, but let's say you find out from the family that the patient never wanted to be intubated. In the US, we do an extubation at that point. And under US law, if you intubate and did not know the wishes of the patient, you can go ahead and extubate, and it's this equivalent as not intubating the patient at the beginning. So what is the situation in India? Let's say, the family comes and provides clarification and says, our father never wanted to be intubated. He doesn't want to be on a ventilator. See, that's like you were saying, it's a fine line between physician-assisted suicide and, withdrawal of care. So this is a difficult choice. In the US, it is a little bit clearer. But when we do DNR discussions, we have to be very specific. No drugs, no CPR, no intubation. What do you want and what do you not want? So that we have clarity there. The problem is, like I said, if you don't have clarity, then, if we're going against the law and stuff, this can be a dangerous situation for the physician. So again, I think without clarity, it becomes a problem. But you can explain, if you can, how does it work in India?
Okay. Thank you, Dr. Kela, for the question. Where this is, withdrawing of care, withholding care is more clear, but withdrawing care is more controversial. And I cannot give you a definite answer or a clear answer that it is okay or not okay. The Supreme Court has said that in certain... Yes, Anu.
Yeah. So we do have an answer for this. So even though there isn't a law which clearly states what is to be done in this situation, we do have a judgment, which is by Justice Karchu, if I'm not mistaken. And it's a pretty long judgment, and one part of it actually has these sentences which says, in the absence of a particular law in our country, we may well use precedents from judgments from other countries or existing laws from other countries. So this would probably apply in that context. There, for something to be illegal, there needs to be a law against it. So there is no law against withdrawal of care. There is a law against active euthanasia. There is
Yes.
no law against, passive euthanasia or withdrawal of care. So that premise would apply here, and that gives us enough protection in the law to actually withdraw care as well.
So while there is no law against it, what many still practice in India is something called leave against medical advice or discharge against medical advice. A lot of it depends upon the institutional policies where you are. Some hospitals agree to withdrawal of care, and yeah, Sashi.
No, please continue, Anisha. I'll just talk in the last.
Okay. So a lot of institutions practice these things differently. Some of them, where say it's a brain dead patient, they do extubate the patient and allow them to pass away. But in certain cases, they may not accept withdrawal of care. In such patients, they counsel the family, the patient, and the family takes the patient home against medical advice, and then they remove and withdraw life support there. It is not done in the hospital setup, but once the patient is out of the hospital compound, there is withdrawal of care. So this is not the most ideal way, but this is the most common way in which withdrawal of care is practiced around here. This is because there is so much, yeah.
Dr. Chandrasekhar and Shashi, we were on a communication workshop at ISCCM, and just for the viewers, we will also be having a longer session in continuation with this thread on medical law and ethics, and probably get a couple of speakers on this same topic as an extended curriculum. But one of the things is that most of the authors, especially the author who wrote the ISCCM guidelines, for example, clearly believes that the discharge against medical advice is
Is not
actually
good.
unethical,
Yeah.
right? So the process that needs to be followed is that, first of all, if it's a brain dead patient, the medical team is not under obligation to continue care. You can disconnect the patient from the ventilator and extubate at that point. That's not a problem. Of course, you'll need to have the communication framework in place before you do that. But withdrawal of life support is supported by the ISCCM, which is a governing body. And like Sanu said, if there is a governing body that gives you a guideline or a roadmap, you can withdraw care. There's no law against it, and that is a direction in which many institutes are moving. And we hope this will get more and more clarified as time goes on. It's going to be about motive and consent, and most speakers realize that the left against medical advice and discharge against medical advice is a very confrontational and defensive way of doing it, and probably should be abandoned going forward.
Yes, Sashi.
See, I wanted to just bring in one point that law is only under the basic ethics of human
Yes.
medical thing. I mean, if we are able to follow to the core the ethical aspects or the four baseline principles of autonomy, beneficence, doing no harm, or justice, I don't think there will be a huge amount of repercussions in any way. And there will always be, I mean, law is all about a case, how it is given a judgment, and then the thing is made. There would be some amount of written thing in the constitution for each place or each region, and doing the right thing will be the end of it. So from a withdrawal aspect, I completely agree that having leaving against advice, going out of the gates of the hospital, and then that is more as a defensive part where people would want to ensure that they are not responsible. But if you think about a different way of looking at it from a patient or a patient's family perspective, on the patient is may not be able to make decisions at that time, but from the family perspective it is extremely traumatic, and I don't think it's the right way to do. I think one biggest thing we can potentially do in hospitals is to spend time, just like what you said, with all the communication happening throughout for ensuring that there is an end of life. I think that makes law, no matter what, both in terms of the not being, I mean, the word sued is I mean, not getting sued, because you end up being a part of the family and help them make the right decisions. At the end of the day, the patient is making the decisions as depending upon what the health of the patient is going to be, or what the sickness the patient can tolerate. I still think that Lama, Dama, all these words are not the nicest
actually
thing,
not
like
good.
every one of us
Yeah.
in this.
And the patient, we take away the fundamental right of, death with dignity, isn't it? We don't give them analgesia. We don't give them the care that they deserve. So I agree that Lama and Dama, they are not the best ways in which we should withdraw care. And the trend is slowly changing over the years. There is more acceptance to withdrawal of care than it was like probably 10 years ago.
Yeah.
Sandesh?
Thank you. Sandesh.
To add to the point what Shashi just alluded to, I think it's just a false reassurance that the hospitals feel by doing these Lama and Dama procedures. And in fact, we have seen cases right in India, especially I think in Delhi, where hospitals have been dragged to court when they have done these process at home. Extubations at home also got pulled into cases against them because that was unethical. So you can get into actually issues, or you could end up on the wrong side if you do that practice. That's what I wanted to comment on.
Yeah, that's right. Rajendra?
Raja?
Yeah. Another problem with this Dama is that if the patient dies, the death certificate becomes a problem, because hospital cannot provide a death certificate because the patient expired outside the hospital. So that is one of the major things. In these situations where, as one of our doctor said, if the patient gets intubated in ER and then, patient and family actually did not want, and because extubation is not allowed here in our system, what I do in such cases is, I just leave them on minimum ventilatory support. I don't, initiate aggressive management with the inotropes. Or if the patient requires dialysis and all, I discourage, after the communication, I discourage the family to do for all that. And I tell them that, just give some more time, and, the person should pass away on his own. So I think leaving the ventilator with some minimum ventilator support and not initiating all other supportive care will definitely allow the patient to pass away in, 12-24 hours. And that gives the family enough time to, accept and let the things become smooth for everyone. From the hospital point of view, from our legal point of view, and even for the patient to accept it. That is what I have been practicing.
Yeah, so Dr. Rajendra, actually the non-extubation policy may be a hospital policy. There is no law to my knowledge that prohibits that. So, for example, if a patient has been started on dialysis, there's no law that prohibits you from stopping dialysis, right?
Yes.
So similarly, if a patient is on a ventilator and the family desires non-escalation of care or even cessation, as long as the communication channel and the documentation is recognizable, the consent is there, and the motive is very clear, there's no law that prevents that. So I know that there are hospital policies that are saying that, oh, you can't extubate, but that is purely, partial misinformation and partial defensive nature of what the hospital policy wants to do. I don't think by law it says that you can't, because we do that routinely for other organ support anyway. Yes. The doctor decides we are not going to dialyze and you stop dialysis. You could make the same case that, you can't stop dialysis because you've already started it. So these things are, I think, some arbitrary laws that have attained almost mythical status. And, we can be cognizant and careful about these things.
It is more to do with having lack of knowledge of what is right and wrong and what is permissible by law. having no clarity is making people do, these things. It's more of a defensive behavior, as Sashi said, that they want to make sure that there's no litigation on them, because there is a lack of knowledge and there's a lack of clarity.
No,
Yes.
another thing, Anisha, my personal feeling is that, when we extubate the patient, most of the time, that few hours, whatever the patient is lasting, that gasping thing and all is not comfortable, the noisy breathing and all. So whether it's right or wrong, I just leave them on very minimal support, or maybe even, just endotracheal tube connected, and I just allow them to breathe comfortably without that noisy breathing or the gasping feel, so that, family don't feel that, the patient is suffering. And just couple of hours, if you wait, invariably the patient passes out.
Yeah, so this is basically withholding of care, isn't it?
Yes,
It's not.
yes.
So it's a very fine line of how people manage withholding and withdrawing and non-escalation of therapy. And as I said, though there is, the law says it's okay to withdraw care, most of the institutes are not still completely open, and each one, sort of has their own hospital policies that they follow. So the ideal way is to, if a patient is terminally ill and would not benefit from treatment, we withdraw the care and keep the patient comfortable through the remaining period. Give adequate analgesia, sedation, give the family time to be around the patient. That is the ideal situation. But yes, we are slowly moving towards there. We are not there yet.
True.
Yeah, I think two key takeaways or points that I want to highlight is, number one, the courts very explicitly have in certain judgments recognized the right to die with dignity. That is an absolute human right, and the Indian courts do recognize that right. And number two, there is enough in the law to withdraw care, because it's like I mentioned earlier, absence of a particular law doesn't mean something is illegal. There is no law which states I can sit on my chair and drink coffee in the morning, but drinking coffee in the morning is not illegal, right? The same premise applies here. So for something to be illegal, there needs to be a law against it. Absence of a law doesn't make something illegal. So if there is a law which is not present in the Indian judicial system, or there's no clarity on a certain law, then on a case-by-case basis, like Shashi mentioned, they look at international precedents, and pretty much in the Western world and even in the non-Western world in certain countries, there are very clear guidelines and legal framework which exists, and Indian courts do take precedence from other countries as well. And this is also mentioned in a couple of judgments by some Supreme Court justices. So we do not have to fear persecution as long as we are acting in the patient's best interest and recognize his or her right to die with dignity.
The other issue that I think you brought up and is very important is the clarification to family that they're not turning off the ventilator. They're not, turning off support. They're simply conveying the patient's desires to you, and we take it on ourselves to say, okay, I'm fulfilling the patient's desire not to be on a ventilator. It is not you that is making the decision. You're simply telling me what the patient would have wanted, because I didn't know the patient before they came to me. The other part of, not extubating or putting them on minimal support, the problem there is, if the patient survives, how long do we wait is the real question. That, and I've had cases where, the patient, actually we extubated, the patient survived for several days. I'm not going to smother the patient with a pillow, but you have to understand that this is sometimes an issue that we have to think about, and we have to talk to the family. The other question that I've had families ask me, a very, very valid question, is, do you leave them in the ICU or do you send them out?
So our practice here is to, if they accept, non-escalation of therapy and we're not doing any interventions, then we shift them out to the ward and allow the family to be there. Sometimes for social reasons, they may not want to be in the ward because they may not have somebody who's there 24/7. Then we make the similar arrangements in an ICU, in an isolation room, where the family is able to take care of the patient and be with the patient.
Okay, and that's a very reasonable approach. I mean, I've had administrations come to me and say, you cannot keep the patient in the ICU if you're not doing anything. We need that bed for somebody else. And that's always a challenge. But again, I think, if the administrations are understanding enough to do that, I think that's a good thing.
Yes. So they accommodate, at least in the Indian setups, they do accommodate these things. Generally, we try to move them out because it is more economical for the patient, and plus we're not doing any intervention. The cost burden becomes quite large on the family. So we educate them, and they can spend the entire day with the patient. Generally, ICU is not a setup where the family can be there 24/7. But a ward, the relatives can be with them, through the day. So we prefer to move them to the ward so that the family can, spend whatever time available with the patient.
Very good.
So as we know, in India, as yet, palliative care is still in the rudimentary stage. We are slowly moving to a better, a system. But there are lots of barriers that come in between end-of-life care. The main factor probably limiting end-of-life care is an understanding of the disease process and prognosticating and being sure how long the patient would survive. So the physicians hesitate to tell or counsel the family that it's time to move to a palliative approach. Then there is a fear of law among doctors, and sometimes physicians just lack communication skill and are not able to pass the message effectively to the relatives or make them understand what the real scenario of the patient is and what his prognosis is. And another thing is there is fear of death, both in the patients and sometimes in the doctor as well. So they want to keep continuing care till they can. So these are some of the barriers. Also, there are religious components, they are psychological. We'll come to certain scenarios where we've had, the psychological and social aspects that hamper end-of-life care and end-of-life decisions. So a lot of factors put together limit and become barriers to, move towards palliative care. So this shows the majority, the biggest chunk over here, the prognostic dilemma, where the doctors are not sure or the treating physician is not sure in which direction the patient's disease is going to progress, what his mortality or morbidity is going to be like. And there is also fear of the other thing is there's reluctance on the intensivist, and there's reluctance on the family members to move in that direction. So why is end-of-life care important? So end-of-life care, as I told you, it is not only about caring for the patient when the patient is dying, but it is to make the entire journey smooth, comfortable, pain-free, for them to have good functional capacity for whatever period that they are living. So they live in dignity and they die in dignity. That's the concept of end-of-life care, isn't it? So it provides improved quality of life. And once they have a proper care plan for the patient, it decreases the number of hospital visits that the patient comes for. The number of ED visits decreases. And this also decreases the cost burden that the patient experiences by recurrent and multiple admissions to the hospital. So there are articles which have actually looked into, delayed initiation of end-of-life care. And it says is when you delay decisions for end-of-life care, it only increases the antibiotic usage. It increases the medical and surgical interventions that you do in patients. And this does not at any level increase the satisfaction of family members. As of now, there are lots of challenges in moving towards end-of-life care. And this is mainly because there is less awareness about palliative care. A lot of people in India, they're still in rural pockets. They don't even understand or know that there is something called palliative care. even for doctors for that, many of them don't know that they have these facilities available for the patients. There are regional or socioeconomic and racial ethnic group influences that limit them moving towards these options. And whenever you have challenges, we should take them as an opportunity to build a better healthcare system and to grow in that direction. So probably what we should do with this is increase the access to primary palliative care. We need to create more awareness among people as to what palliative care is. The healthcare system can make provisions and have clear laws with the end of life care decisions, so that the physicians are not confused, they're not worried of how it may impact them. And having end of life discussions as part of the training of medical students will also help in moving this, as in a more structured, like how you run through rotations in different departments. Having this in your curriculum is also useful for them to be aware of this option and taking it forward. So the primary goal of end of life care is quality of life, quality of death, and it is about putting the patient first, putting the needs of the patient first. We have some case scenarios here, like the kind of discussions we just had, so we could probably discuss this. So we had a lady, 63-year-old. She was a nurse by profession and was diagnosed with carcinoma of breast, which was already metastasized at the time of diagnosis. For 3 years, patient stayed without therapy. And this was by choice. It was her wish that she did not want to be hospitalized. It was a wish that she didn't want any surgery. She didn't want any part of her body to be cut. And she opted, to just take care of herself at home in whatever way she could and continue with her life. Over a period of time, she deteriorated and then developed pneumonia. She had a bed sore around the inner region, and she also had a large chest wound. Okay, it was because of the extensive local disease. The daughter, who has been with her through this entire journey, has brought her to the hospital and admitted her. When she came into the hospital, there was increasing oxygen requirements of the patient. The chest X-ray, where every alternate days when we did the X-rays, there were worsening infiltrates. Her WBC was increasing. We tried to talk about palliative care, but patient relative, that is the daughter, did not agree for it. So we continued her care, and she stayed in the ICU for 2 weeks, and eventually she died. So what would be your take, or how would you think would have been a better way to go about this, and what problems do we see keeping end of life care in mind when we see this patient? Would anybody like to kind of attempt it?
Actually, in India, the mindset of the patient relatives is very, difficult. They are very difficult to convince in terms of the disease severity and the outcome. So,
Yeah.
So they are always in dilemma. They don't know the exact thing about by what we mean that we're not doing any aggressive management. So they just say that continue medical management, don't do any intubation, dialysis, and all.
Yes.
So there should be any, demarcation as to what medical management and how much should we proceed in such extensive cases.
So Anisha, in this case, the patient was awake and alert, right?
She was drowsy. Initially, she was awake and alert. She came to the hospital on her own, but over a period of time, like in the next 24-48 hours, she deteriorated, and her pain was so high that she was on like fentanyl infusion. So she was not very coherent, and it was not very easy to communicate with her.
No, but at the beginning, if we have to prioritize autonomy, from an autonomy angle, the patient has already made it very clear that she does not want hospitalization, right?
Yes. So this is what I wanted to highlight. This patient has a cancer. She has a metastatic disease. She chose not to take any chemotherapy or have any surgical intervention. So getting her to the hospital itself, there was a breach of autonomy there. Fine, the patient was conscious when she came, so she agreed for medical therapy. But she definitely didn't want any life-saving procedures. She did not want any interventions. She did not want too many, medical things done to her. So there's a breach of autonomy there. I just finished this Sandesh, and I'll kind of give the other things. So this patient, the problem here was one, the mother decided not to opt for therapy. The daughter, along with this, supported this. So when the time came where she was passing away, there was a lot of guilt that the daughter experienced, that he did not do what was necessary, and then now she didn't want to give up and do everything that was possible. So autonomy was, it took a back seat, and the psychological component of the caregiver came forward, and the actual care that the patient should have received deviated. Yes, Andy.
Yeah, this is one of the problem with Indian setting and Indian healthcare, and maybe the culture that we are in, right? So patient autonomy comes last. We are kind of paternalistic in decision making. We talk to patient attenders and try to make decisions, and we don't go. And the setup is such that let's say if this patient was an NHS. The hospital would have made sure that they would have done everything possible to give that autonomy to the patient come what may. They wouldn't have considered the patient's bystanders or attenders wishes here, right? They would have even taken them to court if that arises. But which hospital or setting would do that in Indian setting? So that's the question, right?
Yeah.
Unless somebody comes up,
Sorry, can I say something?
Yes.
Yeah.
All right, so thank you for this. I think in this situation, apart from the fact that even with respect to autonomy, remember that this particular patient is a nurse. So that means that she is competent. That means that she knows what she's saying. And so there's no issue of maybe she was, what's the word now, I've forgotten. But there's no issue of maybe she doesn't understand. So it's totally informed. I mean, of course, you can talk about the Indian context. I can talk about the Nigerian context, where many of these things too are still a bit of a problem. And it's not as straightforward as the NHS, where even when you talk with relatives and the patient is medicated, you always want to ask them, what are the patient's wishes? Not what is your wish for the patient, but what is the patient's behavior? And we've had a couple of patients like that who have come into ICU, and then having discussed with the relatives, we realize that these are patients who have refused medication from the onset and do not want to be hospitalized or to be heavily medicated. And so for those reasons, we've had to de-escalate management, because at the end of the day, it is patient interest first. But then I can imagine in my home country, Nigeria, having this kind of conversation is going to be very difficult, because there are going to be different people who are going to come up. Some other family members are going to feel like, oh, we're the ones paying, and so we must insist that this is what should be done, and because where laws are not as strong, and the physician is not, it's, in those kind of situations, it's not as straightforward. But yes, I think another point to be mentioned in all of this is that this lady is a nurse. So she is very well informed. So she's not just a regular person. This is definitely her decision, and it should be honored.
Unfortunately, the patient came conscious to the hospital, so she wanted therapy, is what you would imply, because she came to the hospital. But what is the extent of care she want? She was not in a position to give us details by then. And very clearly, this question was put forward to the daughter, that it is not what she wants, it's what the patient wants. But when she is the surrogate decision maker, it's a very tricky line for me to say, no, this is what the patient wants, because she's become the surrogate here.
Rolly?
So go ahead.
Yeah, if it's not documented that that's what she wants, then I believe we have to go with the caregiver, because if it's not documented, then it's what the caregiver says that she wants. We just only hope that she'll be honest about it.
Absolutely.
Rolly, you wanted to say that?
Yeah. In all this, what I feel is that although she had made that decision, the point that Sanath has pointed out, there was no advance directive, right? There's no written documentation of that directive, and that is not there in most of the cases in India when we see patients coming to the ICU with an advanced illness, in which we think that it is a palliative care, but it is difficult for the family to take it when it actually happens to them, when they're actually dying. It is a suffering for the family, entire family, to see their near and dear one going through that process. And probably with this case, it's such an important discussion that this palliation should not have come at this admission when she had been admitted with a pneumonia and a bed sore. Probably this palliative decision or discussion should have been initiated, could have been initiated a long earlier, when she was diagnosed with a metastatic disease, or she was following up with some clinician, if she was. So if the patient is not following up, then nothing can be done about it. But if they are following up with some onco surgeon or onco medical onco, or so it comes to a holistic approach involving a palliative care physician, some multidisciplinary approach in which an OPD discussion of such things happens, so that the family also gets to know what complications they would anticipate in the coming year. So patient won't die suddenly. It would be a process which will happen, and it would be very, very difficult for the family to take it at home without any support system. So that support system of a palliative approach, a home approach, should be coming at a very early stage, is what we require in an Indian perspective, is what I feel. So when that comes in, probably it would take long, many years or a time to arrive at. But that becomes a very important part, because convincing them at the last moments of their life for the last 2 weeks, or this is a very difficult decision. The family feels so guilty that they are not able to do. So kind of getting them into that line where they feel a little guilt free, that no, whatever you could do, you have done. So those discussions happen in the ICU settings, unfortunately. But if those decisions are taken in a pre-advanced way, probably the family would be better prepared, because it is not only the patient who's going through that process, as you have discussed in all your slides. It's the family who's also suffering along with them, right? So I think that holistic approach should be initiated a little early, is what is my thought process. Whoever is the treating physician should initiate those discussions, and kind of can initiate and can make things better for the family to go through the end stage. Yeah,
Agree.
that's my thought process about it.
Angela, do you want to tell something?
Yeah, in addition to all this, I think the hospitals should equip their advocates or lawyers to set up protocols with regards to end of life care. I come from, like Dr. Beckley has said, I come from a country, Nigeria, where we are very religious, very conservative, very traditional. So it's very difficult for us to let go of our loved ones, so to speak. But if the hospitals have a policy where in a certain scenario, the physicians can draw a line between tradition and science, it will help a long way to help the family take these decisions better. And then clinicians should also bear in mind that they should carry the family members along in treating their patients. A lot of the times you find physicians taking care of the patients and leaving the family in the dark. The family doesn't know the extent to to damage or to life or death that the relative is in. And so the hospital should draft out policies. Physicians should do more in explaining to the family, do more right from the beginning of care, not just towards the end, right from the beginning of care. You tell them, that you lay out the prognosis, you lay it out plain before them, so they know whatever decision they are taking from an informed point of view. That is my take. Thank you.
I just have one point to say. Thanks, Angela. I have just one point to say, that I mean, we are talking here about India, Nigeria, and Western countries. I don't think there's any difference between people and families anywhere where they are not prepared to see or expecting what end of life is going to be at home, and doing that. Very, very few systems may be so robust, like what Rolly is mentioning. And I still think that getting there, it takes ages to make end of life or advanced care directive, and if legal system has to start accepting it. I still go back to the fact that uh, making these decisions very early, just like what you mentioned at admission, not coming into ICU. But there is one other point that, see, at the end of the day, we are trying to treat two or three things. Full autonomy and patient centric approach is a greatest thing to do. There is we also take the responsibility of ensuring that the families who are there are also able to accept and come to terms with the actual situation. We should not be giving any response. I mean, we are not. We should tell them that they are not taking the onus and all those things is right. But we should take this responsibility as physicians, that even the family at the end of the day, after 3 or 4 years, don't feel that they could have done a little bit more and a little bit less, keeping it extremely reasonable about the reality of the situation for the patient itself. I think that it's not only the patient we are treating, but also to a certain extent the psychological aspects of the family we are treating in these places.
You made a great point there, Shashi, and that's the reason why these decisions cannot be done in a hurry when patient arrives in emergency. So we don't know the clarity, we don't know the family yet. We are meeting the family for the first time, and it's not just it's a team approach, right? There are specific people designed to do this, have these conversations. The entire system should be conducive to do that. Just having one conversation with the patient and taking these end of life decisions is not easy, and especially in systems where we don't have the supportive framework, it's really difficult, and that was a crucial thing for this particular case.
Correct. Angela? Yes, Angela. And okay. Chandrasekhar? Chandrasekhar? Or
The only other issue is if you don't have a system in place, you may have to think in terms of providing clarity. This is the thing. You, as intensivists, understand autonomy, all these principles that you're laying out. The family may not understand these principles. So it takes a little bit of time, but take the time to counsel the family on these principles, so that, let's say, the daughter that's helping manage this lady, that they understand clearly it is not her decision, it is her mom's wishes. And that's the way you really have to kind of bring the family back over. It won't necessarily click on the first conversation you have with the family. In fact, it usually takes a couple of days of us talking with the family, and explaining the situation and putting it before them and saying, listen, you guys really need to be thinking about this, because this is unfair to your mom, because that's not what she wanted. So you really have to kind of bring the focus back to the patient, and then allow the family to let the issue sink in.
Angela and Sarah, you had something to say?
Yeah, thank you. Can I just one last thing?
Yes.
So in all of it, the only other thing I just wanted to mention is that something I had a bit of conflict with when I came into the UK was realizing that sometimes some of even these palliated patients actually come into the HDU for some time. And then because my natural tendency will be to say, no, they're not going to come. But then something that was explained to me was that when you can't take that as a whole. If, for instance, a patient has a pneumonia and the pneumonia is actually potentially reversible, then that in itself can be dealt with. The only other thing is that we might now then put limits of care. And so we might decide if this patient is appropriate for invasive ventilation and things like that. But why I mention that is because someone had mentioned that the ICU is the last place to keep a palliated patient. There are a few situations where you might have some things that are reversible. And so you might bring them just for a short period with definitely limits of care, just to be able to tie them through a certain part. And then after that, they go back to the wards.
I agree.
Thank you.
I agree with Sarah. If there's a potential reversible condition, then the patient would get benefit of that.
Angela, did you have anything to say? That might be my mistake. Okay.
I agree with the discussions. Thank you.
Do we have
Anisha, you can-
time for another case discussion? Or
I think we are running out of time. I think what will happen is we'll have more of medical legal aspects and workshops and discussions in the near future in this academics itself. So we probably do more discussions at the time. Angela has something to say as well. Again,
Yeah.
no.
So I think
Okay.
the take-home points would be, when you have a diagnosis of terminal illness, start thinking about palliative care simultaneously. It is not that when you say palliative care, that the patient is going to die, but it is about giving them a quality of life starting there and focusing on needs from all aspects for the patient. Once you have a decision about the care plan, document as far as possible. I think Angela has a question.
Sorry, I'm kind of distracted. Sorry.
Okay.
Sorry about that.
No problem. So it is helpful to have some amount of documentations of what the wishes the patient has. And once you're documented, it is the best thing to have your caregiver on board with you. It should always be a shared decision making so that there is no confusion. There may be a point where the patient is lucid and able to tell you what he wants, but there may be a point where he may not be able to tell you what he wants. And at that point, the caregiver has to take the role of the patient and make decisions. So it is important that everybody is on the same page and there is a clear plan and they're not sort of deviating from that. Mahima has a question.
Mahima, you have a question? No, that might be a mistake as well. Thank you, Anisha. Thank you.
Okay. Thank you, everybody.
Thank you all.
Thank you, Anisha.
Thanks, Anisha.
Thanks.
Great
Bye.
talk. Thanks.
Thank you.
Thank you.
Thank you.